All right, hopefully everyone can hear me. Welcome to rounds on April 3rd. I decided Bruce to use this. Can you close the door? Hello, welcome. So after last rounds, I sent the YouTube video to my dad, who watched it, and he said, Gillian, you say way too much. So I'm going to try my best to not say it today. I should take a page from Megan's book because she hardly ever uses verbal fillage when she's presenting. So here we go. The first case that I will present is a horse. It is a 21-year-old warm blood gelding. The history we got was anterior stromal ulcer, cataract, thesis bulbi, uveitis, and blind. There was no glaucoma. And then they said that there was non-ulcerative keratoconjunctivitis in the other eye. So here's the eye. When we hemisected it, there is the iris here, and then here's the lens, and it's cataractus, so it's a little bit opaque, which means it's cataractus. And then there are these dense white strands that are coating the ciliary body and the posterior iris, and extending maybe onto the peripheral choroid. It's really hard not to say or ah. Anyway, so those are the findings that we saw grossly. And so now we'll go ahead and jump into the histology.
Hey, Gillian.
I do have a slide with the entire eye, the entire globe, but I am going to show you some smaller sections, and it would help if I switched to that program.
Hey, Gillian.
Okay. I'm going to show you some smaller sections which illustrate the lesions just as nicely as the large slide and are much smaller and easier to deal with. So here's a section where we have the cornea, and here's the iris, and then here's the ciliary body. Even from this low magnification, you can see that there is a lot of pink stuff adhered to the ciliary body.
Gillian,
and then there's also some busyness going on in the cornea.
Nope.
I can hear you, Kelsey.
Oh. I don't think Gillian can hear me. Gillian, we can't see your screen.
I know, I'm trying to call Megan right now. I don't know who else to contact, and I'm not at the vet school today.
All right, great. We could start over again. There's the globe with some white stuff on the surface of the ciliary body and the posterior iris surface, and there's a cataract. And here we are looking at the slide. So as I was saying, there's some stuff happening in the cornea. There's a lot of pink stuff adhered to the ciliary body plique. And then in the ciliary body stroma, there's some basophilic areas, and also in the peripheral choroid, which is inflammation. So we'll start here in the cornea. Here is an area where here's the epithelium, and it is very poorly attached right here. In fact, it is not attached. And in these areas, the epithelium has lost its polarity. So if we move over to the left here, where it is actually attached, there is a decent basilar layer here, which is attached very nicely to the anterior corneal stroma. And then we move into this area where the anterior stroma is mineralized, and then the epithelium is not attached. In addition to not being attached, it's also torn multifocally. So this is the definition of an indolent ulcer, where we have areas of epithelial non-attachment, and then exposure of the anterior corneal stroma. In this case, I'm not sure if the mineral occurred first or second in relation to the ulcer. And then in the corneal stroma itself, we have a number of inflammatory cells and blood vessels. So we do have a decent keratitis. And interestingly enough, we have not just the usual sort of few neutrophils, and here's some plasma cells. We also have a number of eosinophils here, and I'm not quite sure the significance of those inflammatory cells in this case. So let's move back into the globe now. And actually, let's start right there. So in the anterior chamber, just subjacent to this ulcerated area, this is the corneal endothelium, or no doubt the corneal endothelium is in there somewhere. And mingling with it are numerous inflammatory cells, including some larger cells, some of which actually have melanin in them. Okay, that's really off center. That's annoying. There we go. So these larger cells are actually melanin-laden macrophages. So keep that in mind. It's a common theme in this horse eye. When we move back into the iris, you can see these big old blood vessels right on the surface of the iris. That is consistent with the fact that there is a pre-iridal fibrovascular membrane here. And when we move back into, this is the trabecular meshwork, which is looking fairly normal structurally for a horse. And when we move into the uveal stroma that's associated with this trabecular meshwork, we once again see a number of inflammatory cells. So most of these cells are mononuclear cells, so they're lymphocytes, they're plasma cells. And then also we have a number of these larger cells that have melanin in their cytoplasm. No doubt some of them, especially the elongated ones or any stellate-shaped cells, are probably uveal melanocytes, the native uveal melanocytes. But the rounder ones, some of them are probably melanin-laden macrophages, much like we saw up against the back of the cornea. So here's another image where we have some plasma, here's a plasma cell, some other cells, probably lymphocytes, and then a number of these cells with some looser clumped melanin, and those are probably melanin-laden macrophages. And as we move back onto the surface of the ciliary body, we have all this pink stuff. And whenever we see pink stuff in a horse eye that's stuck to the ciliary body, we start to think about amyloid and equine recurrent uveitis. So all of this pink stuff is amyloid. I did not do a Congo red, but experience tells me this is amyloid. And then this is a lot of amyloid. When you look at low mag, this is an extremely thick layer of amyloid on the surface of the ciliary body. There are also some little purple dit dots here, which are inflammatory cells that are kind of mingling with that amyloid. And also there is a cyclitic membrane with some collagen and some spindle cells. So there is quite a cyclitic membrane here as well. Let me go to the other section. So the other hallmark feature that we look for when we're diagnosing equine recurrent uveitis is eosinophilic linear inclusions in the cytoplasm of the non-pigmented iridociliary epithelium. So all of these red things here, here's some that are actually linear, so they're cut in such a way that they're linear shaped. So that is and here up here are probably some that are cut in cross section. So these are the characteristic eosinophilic linear inclusions that we see most frequently in cases of equine recurrent uveitis. Now we'll go back to the slide with the entire eye to show you the lens, because there was a cataract as well. So here's the lens. This is the anterior lens capsule here. And in the subjacent lens cortex, you can see there are multifocal accumulations of basophilic material, which is mineral. And then there is also degeneration of the lens fibers. So there's some cortical lens fiber degeneration and mineralization, which is consistent with cataractus degeneration. The lens capsule is also slightly wrinkled, so I did end up calling this a hypermature cataract. When we go back to look at the retina, it exhibits diffuse full thickness atrophy. So there's just not a whole lot left of this retina. Oops. Occasionally, you might find a ganglion cell still remaining. These are probably cells of the inner nuclear layer. So the nuclei of the outer nuclear layer, or the photoreceptor layer, are diffusely gone. So this is diffuse full thickness retinal atrophy. I thought the optic nerve head was within normal limits, which is consistent with their diagnosis of no glaucoma, or indication of no glaucoma. And sometimes the retina is also infiltrated by some inflammatory cells, which is what is happening right here. So to summarize this case, let's go back to our PowerPoint. The most important diagnoses are moderate lymphoplasmacytic and histiocytic panuveitis with melanin-laden macrophages. And those findings are consistent or suggestive of equine heterochromic iridocyclitis, parentheses, and keratitis. And then there was also ciliary body amyloid and intraepithelial linear inclusions similar to that seen in equine recurrent uveitis. So these are two diseases that we see in horses, and occasionally they collide, as in this case. So we have features of both equine recurrent uveitis with the amyloid and the inclusion bodies, or inclusions in the iridociliary epithelium, and also we have presumably destruction of uveal melanocytes in the anterior uvea with melanin-laden macrophages. In equine heterochromic iridocyclitis, or HIC, is easier to say. Other features that you commonly see are keratitis, which in this case, there wasn't a whole lot of keratitis that was not directly associated with the indolent corneal ulcer. So I'm not sure this one really counts as having the keratitis part of that syndrome. But also iridocyclitis. So yes, we have inflammation in the iris and the ciliary body. And characteristically, there is what we could call pigment dispersion of sorts away from uveal melanocytes, and it's captured in uveal melanin-laden macrophages. So this is a little bit of a curious case. Sometimes we see cases of HIC that have no amyloid. Sometimes we see cases that have amyloid and the pigment dispersion. We're not really sure what exactly it means. It's very possible that the amyloid itself is simply an indication of chronic inflammation that goes along with a lymphoplasmacytic uveitis. We definitely have cases that don't have that. We also have cases occasionally of cases, meaning just equine eyes in general, that have lymphoplasmacytic uveitis, but no amyloid and no linear eosinophilic inclusions. We also have cases of heterochromic iridocyclitis that don't have amyloid. So anyway, this is just a confusing case. I think it's confusing to clinicians when we give them these diagnoses, and it's confusing to us when we see them because we're never really sure exactly what it means. And are there any other things that I've forgotten?
The only thing I think it's hard because we don't know, as you mentioned, but the corneal lesions are interesting. You know, the keratitis part of the disease for me always seems to be more a secondary event from the endotheliitis than anything else. So it could be that there was corneal edema, then subepithelial clefting and indolent ulcer formation. The presence of eosinophils is also interesting because we don't see that very often in the cornea, and the fact that they describe non-ulcerative chronic keratitis makes me think they were thinking about kind of a stromal keratitis like immune-mediated keratitis or a eosinophilic keratitis. So who knows if there's a background of eosinophilic keratitis, along with the edema, along with the ulceration from Higgs. So as you said, multifactorial case where it's really hard to pinpoint a specific sequence of events.
Additionally, this case, so the retinal atrophy is not typical of either ERU or HIC. The history we got did not mention anything like intravitreal gentamicin, but I could see that could lead to full thickness retinal atrophy like that. But that certainly actually explains the blindness that they reported clinically, is the retinal atrophy more than anything else, especially when they did not report glaucoma. And also HIC is reported to, for the most part, be a bilateral disease. And they did already mention that the other eye has non-ulcerative keratoconjunctivitis. So maybe that's part of HIC, who knows? Or maybe this horse has some sort of eosinophilic conjunctival inflammatory disease that is related or not related. Who knows?
Yeah, the reason I'm thinking is if you got a keratectomy or a corneal biopsy from this case, and we saw those numbers of eosinophils, we'll definitely comment on eosinophilic keratitis, right? So just to muddy the waters a little bit more, right? At how those things are not that straightforward.
And also, I should just mention that really no one knows the cause of HIC at all. And equine recurrent uveitis is thought to be sort of an autoimmune problem where molecular mimicry leads the immune system to basically cause a kerfuffle inside the eye. A lot of people have proposed that it's related to leptospirosis. As far as I know, leptospirosis has never actually been found in the eye, but I could be wrong about that. Maybe they found it at one point, and that's what sparked the interest in it. Anyway, so enough about this horse. Just sort of an interesting collision of lesions that we see occasionally.
Collisions.
So, all right, cool. Moving on.
Collision-related lesions.
Okay, the next case is an 8-year-old border collie mix, spayed female. The exam they gave us, or the information they gave us, was initial exam on March 8th, redness of the left eye, which is this one, since December of 2023. So already a 3-month history of eye disease in this eye. The primary DVM treated with neopolydex and oral pred with no improvement. The eye was blind at initial exam. There was diffuse corneal edema, large keratic precipitates, 3 out of 4 aqueous flare, iridovascular engorgement, posterior synechia, incipient cortical cataract. The fundus was not viewed. Ocular ultrasound showed total retinal detachment with subretinal exudate. The owners opted for enucleation rather than blood work for infectious disease. So the dog had a normal CBC and chemistry, but other than that, we don't really know anything else about the dog. The other eye has flare and a retinal lesion, which they said might be a scar, ? And is being treated with pred acetate 3 times a day. It is visual at the moment, as they say. Okay. So here is the eye as we received it after hemisecting. So cornea is always at the top. There is some white material in the anterior chamber, which likely corresponds to the large KPs that they noted clinically. Also, what I should also point out is that the globe itself is a little bit distorted. So we have wrinkling of the cornea, and we have slight wrinkling of the sclera. That can be artifacts associated with fixation, but in this case, I really think that there's early thesis bulbi at this point. The lens itself is actually fairly normal. It's in a normal position. It's maybe slightly cloudy. The iris and the uveal tract is a little bit expanded, perhaps. And then this is the choroid here. So we actually have suprachoroidal material that is this sort of translucent gel with some brown sort of threads going through it, which is hemorrhage, or red blood cells, I should say. And then in the vitreous, there is an actually / subretinal space. I can't remember exactly where the retina is. There is hemorrhage and more of that sort of tan material, similar to what was seen in the anterior chamber. So there's more of that tan material lining up against the fundus there, or the choroid, or the retina. I can't remember where it is. Anyway, so all kinds of things happening in this eye. Let's jump into the histo. Do you know where Megan is? So here, oh, I don't want to do that. All right, fine. Okay, here we go. Cornea at the top. There's a blue dot. Blue dots are usually important. All right, the cornea is wrinkled in section as well. There is some pink material in the anterior chamber. Quite a bit of more basophilic stuff, also inflammation. Here's the iris with some ancillary body with some inflammation in it. There's the lens. And as we move back, this is the optic nerve here. So here's the sclera. I think this is the retina. So the retina is detached. And then here's the vitreal space with some material in it. And then we didn't sample the big clot of red blood cells that we saw grossly, but there's that suprachoroidal space expanded by that material as well. And then we generally put an extra slice in cassettes these days to capture a little bit more of the iridocorneal angle to evaluate for gonio, most importantly. And who knows what else you'll find in there. All right, so there is keratitis and there's corneal stromal vascularization. Not surprising given what's going on inside the eye. Here we're looking at the iris, and there's a really thick pre-iridal fibrovascular membrane there with some inflammatory cells in it. And there are also inflammatory cells in the iris stroma itself. So there are plasma cells and lymphocytes, and that's about all we can see at in this area. Now we're going to go back up to the full cut of the globe. There we go. There's more of the inflammatory cells in the anterior chamber. They almost occlude the anterior chamber completely. Oops. And when we go higher in this area, we can see that a lot of the cells are larger with more abundant cytoplasm and larger nuclei. And these are macrophages. And admixed with these macrophages are some plasma cells, probably some lymphocytes. And then when you start to stare at it a little bit longer, there's just too much stuff here. And some of these macrophages have some refractile material in their cytoplasm. Let's see if I can move to a better spot. Let's find the dot. So here is an organism that's not exactly refractile, or at least not significantly refractile, but you can see that it is actually compartmentalized, which is an example of endosporulation. And then also there are others that are not quite endosporulating yet. They are round in this, when they, at least those that I just pointed out are round. And there are quite a few more of them. Here's another one that's endosporulating. So this is consistent with, so in pathology, we have, I think, 5 options for endosporulating organisms. The one that we see most frequently in the eye that are this size, at least, are algae, most likely Prototheca, which is an algae that does not have chlorophyll. So it's an achlorophorus. I'm not sure I'm saying that right. Algal organism that dogs typically get, non-green. Yeah, non-green, that dogs typically pick up from, unfortunately, drinking standing water where the algae is blooming or growing. And then in other areas, you see the other forms of the algae, which tend to be a little bit more just kind of empty refractile. There might be cell walls maybe, yeah, that have birthed endospores previously. I'm not sure exactly.
Empty packages.
Yeah, there's a bunch of different forms of them that we see, typically all in the same eye. So let's try to look at the rest of the lesions. now that we know that the cause is most likely Prototheca, but of course it could be something else that no one's described yet or whatever.
Chlorella is another one, but I don't think we can make a good distinction histologically, right?
Right.
Yeah.
So here is the material in the suprachoroidal space. So it is proteinaceous fluid with some little strands of red blood cells here and there and a few inflammatory cells. This, I believe, is an account of or evidence of the chronicity of what's going on inside this eye. And when we move just inside so here's choroid. It's sort of very distorted at this point, but all of this is collagen with a bunch of spindle cells in it. There's some big blood vessels. So there are very dense fibrovascular membranes inside this eye, which once again is consistent with quite a long history, which is at least 3 months in this case, actually closer to 4. And also when you get that much fibrovascular membrane formation inside the eye, generally speaking, then there's some sort of contraction or a degree of contraction, and then that will eventually lead to thesis bulbi or shrinking of the eye. Also, I think in this case, it pulled the choroid away from the sclera, and then that resulting space just filled up with fluid. As I said, the retina is, well, actually, as I wasn't sure, but here it is. The retina is at least extensively detached. So this is actually the subretinal space here. The retina is also quite inflamed and probably a bit atrophied. So I think the lens is pretty normal. It's pretty oblivious to what was going on around it. So let's just go back to our PowerPoint now. Oops. Okay, so the most important diagnosis here was moderate granulomatous endophthalmitis with abundant algal organisms suggestive of Prototheca species. As we already discussed, I don't actually know if it's Prototheca. There's probably like others that haven't been described yet or whatever that could be involved as well. This is an animal from Texas. However, Prototheca can occur anywhere. Mostly it's in the southern half of the United States and probably southeast and sort of straight south in the Texas areas. Probably where we see most cases from. Often the number of algal organisms will actually outnumber the number of macrophages, at least. I was actually kind of impressed with the number of macrophages in this case. So often it's even a mild granulomatous endophthalmitis, and most of the stuff that you're actually seeing in the eye is algae. So I thought this one had an impressive amount of inflammation. Once again, that could be due to the chronicity. One of the clinical signs that can be reported in a lot of these cases is some sort of chronic GI distress, like bloody diarrhea or something like that. And that's typically because the organism colonizes the intestinal tract and then disseminates out to the rest of the body from there. Unfortunately, algae does not really respond to any treatments that we can throw at it. So even antifungals don't typically work against it. So it's often, sadly, kind of a death sentence by the time we diagnose it in the eye.
And they haven't reported anything systemically in this case yet, right?
Correct.
Yeah, that's not uncommon. Sometimes by the time we're about to send a report out or while things are being processed, we'll often receive a call telling us that the dog's not doing well and went down health-wise. So
sometimes the eye is the most visible manifestation of disease. Yuck, yuck. Anyway. So the next case is a kitty. We've got a 3-year, 11-month-old neutered male domestic short-haired cat. They describe in the left eye iridodonesis, diffuse iris hyperpigmentation, trace flare, late resorbing cataract, mild pigment on the anterior lens capsule, and IOP of 29 millimeter mercury at time of enucleation while on topical anti-glaucoma meds. They also note that the duration of disease is 2 years, which I think is interesting in this case. All right, so on the gross photograph, this is just a photograph of the other half. The gross examiner didn't think to take a photo at the time of sectioning, and it totally wasn't me. It was me. So this is the other half, and I kind of like push this one through a little. But We have not much lens visible left in the other half, but you can kind of make out the anterior lens capsule still. And basically what the lens looked like in this case in the first half was just like an empty capsular bag almost. So when it was cut, it was practically just like a shell of like that cellophane-like lens capsule and not much else of substance to it, which was kind of cool. And then sort of throughout the vitreous, particularly here, we had these multifocal white sort of floaters in the vitreous, which was very interesting. And then also the vitreous had this sort of wispy membranes throughout it. There was, I believe there was actually a retinal detachment. Yeah. So it's a little bit difficult to trust it in a second half like this, but here's the retina here. And it's not really laying down nicely against the back like it should be. The only other thing that I'll point out on this gross image is you can kind of make out a deep anterior chamber or presumed iridocorneal angle recession here on the gross, but it's much easier to see it histologically. So we'll switch to the slide. So that's this kitty. And then we'll do this. So on the subgross, you can actually really make out what I was saying about the lens capsule that you could have seen originally on the first half gross. Basically, the lens is just this empty capsule with not much of substance inside. From low magnification or on the subgross here too, what I'd point out is again that angle recession, or basically the abnormal angle at least, because there's more to say about it than just that. But you can see the iris leaflet here. And then even the ciliary body is separated from its normal anatomic location. And this is resulting in a very, very deep anterior chamber. And so more on that in a second. But that anatomic relationship there is very interesting. You can kind of also see, although it's going to be easier when we go closer, that there's a wispy network of pigmented posterior iris cysts in that posterior chamber there. We can see the detached retina. We can see all this like wispiness in the vitreous, which we'll look at closer, and then a little bit of hemorrhage sort of centered around the central retina and optic nerve head, which is kind of cool as well. So let's take a closer look. So now we've rotated 90 degrees clockwise. And let's take a look at this lens. So way over here, closer to the equator on this one side, is pretty much the only piece of lens fibers that have kind of remained in the capsular bag. We have these sort of fragmented little bits of fibers, which are actually embedded in a more fibrillar collagen. So these cells here are lens epithelium, and here. So they're basically, they're migrating posteriorly, and they're also undergoing fibrous metaplasia, where they can kind of become more spindle-shaped and lay down lots of this sort of more disorganized collagen, usually lining the interior lens capsule. And basically embedded in that collagen, there's like fragments of remaining lens fibers, which is kind of interesting. You can see a similar membrane on the outside of the lens, which is suspicious. And if we migrate, if we walk along the posterior lens capsule here, we can see this little fragment of lens capsule that just kind of ends and is embedded in the midst of this collagen. And then there's sort of doubling to tripling of the lens capsule, like multiple different layers of it. So this is pretty consistent with the lens capsule rupture. The interesting thing in this case is that if you wander out into the vitreous, those like floaty white bits, as it turns out, are more fragments of lens fibers. So here's some more, very fragmented and just floating hither and thither in the vitreous. And if we look closer at these fragments, there's not much of a response to these. There aren't really macrophages lining them. There aren't really neutrophils responding. And I think that that's interesting. So I think it's quite likely in this case that because the cataract was probably quite advanced, we get these cataracts, which are basically just bags of liquid or bags of liquid with floaty bits of lens fibers floating in them. When you cut into those, they can be like glitter bombs, or especially if they have cholesterol, they can be very sparkly, but not in this case. But they can be like basically like an explosion of little fragments of lens, and it can kind of go out artifactually into the rest of the globe. I think that because there's basically no response to these fibers that are free floating, that may be most likely in this case. But it is just such a disseminated like fragments of lens here inside the globe and sort of embedded in that gel-like vitreous grossly, which is just interesting to me, and more on that in a second. Let's walk back away from the lens, which I think is the main event, but there's more to see. And back over here to this angle. And so again, the microanatomy here is very abnormal. We have the end of Descemet's membrane maybe about here, and the iris base is like here, and we just have this deep divot here where the ciliary body also is separated from its normal anatomic location. So this is at least a really severe iridocorneal angle recession, which can be a somewhat mysterious lesion. It may be a consequence of booth-thalmus from glaucoma, or it may be trauma-induced. And especially in this case, with a lens capsule rupture concurrent, I would wonder more about trauma and potentially cyclodialysis here. So the separation of the ciliary body from its normal anatomic location could indicate that there's been a tear here associated with trauma. The one reason why I back off of being definitive about that is because often with cyclodialysis, we'd see more remodeling at the site, like fibrosis, and we don't in this case. But I still think that there's at least soft corroborative evidence that there was trauma with cyclodialysis here to explain some of these anatomic differences. And another thing that's sort of like soft evidence of trauma is over here in the peripheral Descemet's membrane. It's a little two-toned, which suggests that it may be doubled. And then on the other side in particular, let's see, there we go. There's this interesting duplication of Descemet's with sort of a thinner layer here and a thicker layer here. And then in between, there's this interesting protein. And I don't know what this protein is specifically. It's just interesting that it's sort of trapped between the layers of Descemet's. I kind of wondered for a moment if it maybe have been from the lens, but there's no way to prove that without like crystalline stains or things like that. And it could be something completely unrelated. We sometimes see mysterious protein at this location and don't know its significance. Yeah. And maybe completely unrelated.
Right. Sometimes in Descemet's membrane, sometimes in the connective tissue around it, and yeah, we
don't know what it means.
Don't know what they are.
We usually see that in dogs.
Mm-hmm. Yeah.
This is really weird.
It's weird. But anyway, doubling of Descemet's membrane at the periphery suggests that there may have been breaks at some point and sort of regrowth. And it's sort of a soft corroborative piece of evidence for trauma again. We can see similar changes to the microanatomy of the iris base and ciliary body on the other side. And just some other finds. Yeah, so we have a retinal detachment, and then here at the periphery, a retinoschisis. So these clear spaces in between, typically in between the nuclear layers, although in this case, I think the outer retinal atrophy is pretty severe. And then to the central retina here, which is pretty jumbled and difficult to see what's going on, lots of hemorrhage. And let's see. We can see some of these spindly cells percolating out into the vitreous and forming these intravitreal membranes, which is probably what gave that wispy look to the vitreous grossly. And again, just more like tiny fragments of lens just everywhere amongst the hemorrhage here too. And so that's about it.
Yeah, the iris cysts too, right?
Oh, that's right. We didn't really focus on those.
That's another trauma-related thing, cats.
Yeah, common with trauma in cats. Yes. So we have these posterior iris, let's leave that out. All right, we have the posterior iris cysts, which are lined by typically cuboidal and pigmented cells, sort of extended from the posterior iris, posterior pigmented iris epithelium. Often seen with trauma in cats as well. I think actually, maybe briefly, it'll just be interesting to show this. Another thing that I think we see more often with cats and retinal detachment in cats is they get this like really robust hypertrophy and hyperplasia of the RPE a lot of times with trauma. Just kind of cool to show this really quick. So these are RPE cells. You can confirm it for yourself by looking at the shape of the melanin granules in them. They tend to be more elongate, so sort of American football shaped. And that can tell you or help you to tell the difference between other pigmented cells that may be floating around back here. And there's just so many of them, and they're rather big. So for cats, they tend to have this just really robust RPK hypertrophy and hyperplasia with their retinal detachments.
Especially young animals, right? And this is
Especially young animals.
relatively young cat.
Yeah, and this cat had a duration of disease of 2 years and is currently 3, so presumably, or maybe almost 4, but presumably quite young when things happened. So, here are some of the key diagnoses, and the long story short in this case is there's a lot of evidence suggestive of trauma, particularly the lens capsule rupture. So in the absence of intumescent cataract, which we have no evidence that that would be a thing in this cat, spontaneous lens capsule rupture is considered very unlikely, and so it's most likely acquired and therefore most likely trauma. And so that plus the other kind of corroborative pieces of evidence suggests that there was ocular trauma in this case, probably blunt. And up to a duration of 2 years in this cat. So part of the reason why I thought it would be cool to show this case is one, the suggestion of potentially a very like mild reaction in terms of inflammation, at least at this stage of disease management. So basically like no real inflammation inside the eye despite a lens capsule rupture, which I think is just really interesting in the context of like how the immunology of the lens really works. And I think we probably have more work to do understanding it. Because, you know, we have cases where it's like a very severe reaction and we have cases that it's significantly less severe. So that part I think is cool. And then the other part is a cat with potentially up to 2 years post-trauma and a lens capsule rupture, but no tumor. So this cat is truly hashtag blessed, a very lucky kitty. And so yeah, just interesting things to see in a young cat. All right. That's it for this kitty. Oh, I should also make this large. There we go. So the next case is a 53-year-old female common bottlenose dolphin. So these are both eyes from a dolphin. And I'll get you the history. So 12 to 15 years of bilateral pigmentary keratitis, and of moderate to severe visual impairment, particularly in the right eye. At one point, they noted prominent white necrotic tissue when the eye was partially open. So when the eyelids were partially open, there was this white necrotic tissue kind of protruding from the cornea on the right. The right eye was not particularly painful, and basically over time that protruding white tissue decreased slowly in size. So some interesting pieces of history there. So corneal disease in both eyes and this unusual protruding tissue in the right eye, which slowly decreased in size over time. We got both eyes from this case, and this dolphin was euthanized ultimately. And the eyes were received already hemisected and the lenses were retained for a separate project. So don't read too much into the lens absence yet. But we have the right eye, which was the one that white tissue had been protruding from at one point. And you can see, so it's a little difficult with the scale, but this eye was a little smaller than the left. And you can kind of see with the rulers down here that the scale is a little different between the two, which accounts for why that doesn't really look, necessarily obvious. But believe me, it's true. The right eye is a little bit smaller than the left. And the right eye was also filled with this sort of tan solid tissue. The cornea was also pretty much completely opaque. And then the left eye, there's a lot of little floaty bits in the vitreous, but some of that may be kind of float on. The lens absence, which we already said is not necessarily a big deal, and certainly just kind of a cloudy cornea. And we'll take a look now at the histology. The histology, there we go. All right, that is still the cat. So let's start with the left eye. Right, it would help if I did the subgross properly. So we had a little bit of artifactual absence of the globe of the limbus here, but the main thing to show off is the central cornea here on this left eye, which is very, very thin. You can see a remarkable difference between the sort of paraxial cornea here, which is at its more full proper thickness, and the central cornea here, which is very, very thin. It still has epithelium over the top, and we'll look at that closer in a moment. And there's not really much else to report in the rest of the globe. We're going to focus on the cornea for the left, for the purposes of our rats. Let's see. So something that we can already see that's very interesting right at the edge of that thin region in the central cornea. The stromal fibers are all very exquisitely parallel. That's part of how the cornea maintains its clarity. And seeing how the stromal fibers are sort of oriented relative to epithelium is very useful. So there's a bit of an artificial separation here, but you can see that the stromal fibers are kind of sloping down like this. And if you could kind of lay the epithelium back down with your mind's eye, it would be oriented at an acute angle relative to these corneal stromal fibers. So there is loss of corneal stromal fibers centrally, which is kind of like an of course, I suppose, because it is so remarkably thinned. But just to sort of help, and if you have a more subtle case of corneal facet or something like that, you can look for that acute angle orientation. Centrally here, we also have these multifocal regions where the corneal epithelium is sort of sinking or growing into the cornea. But the stroma itself is not looking particularly lytic. These fibers are sort of artificially separated here, but there are still distinct fibers of the corneal stroma. So it's more like these sort of pegs of epithelium growing into the corneal stroma. And we'll talk about that a little more later as well. And then right here, paraxially, next to this area of thin cornea, we have this really thick, homogeneous eosinophilic layer just beneath the corneal epithelium. And then it's multifocally absent. So there's an absence there, there's an absence there. And that layer was actually not there at all in the central cornea. So let's briefly switch back to the PowerPoint. So this is from a publication which is cited down here. And a histologic image of a normal dolphin cornea. So this is the normal thickness of the epithelium, and this membrane here, this sort of homogeneous eosinophilic stuff just beneath the epithelium, is a normal structure in the dolphin, and really in everybody. So this is actually Bowman's layer. And in most species that we routinely look at in Coplow, so like your dogs, your cats, your horses, Bowman's layer is not really visible histologically, like you're not really going to see it. It's sort of more of a suggestion or a visualized thing. In dolphins, as an example, it's really thick as a sort of normal feature of microanatomy. So in the affected dolphin that we were just looking at, what we're looking at is actually a multifocal absence of Bowman's layer, which is really interesting. So we have this corneal stromal thinning centrally, and we have multifocal absences of Bowman's layer. And that is consistent with a dolphin corneal disease, which has been described in the literature, referred to as horizontal keratopathy. We'll put something else up so that we're not, reading it like that. All right. So horizontal keratopathy or sort of keratopathies in dolphins are named pretty simply in the literature based on how they present. Which makes it nice. So horizontal keratopathy presents as a sort of horizontal band of corneal disease centrally, and it has those histologic features, so most consistent with that in the cornea. And we'll switch to the right eye. So the cornea was also pretty cloudy in the right eye, and we'll talk more about that in a moment in the context of what we were just talking about. But the other thing that you want to pick out on subgross is that tissue that was filling the eye is quite pink and fibrillar. And again, the eye is sort of smaller than the left. And you actually lose the uveal or identifiable uveal stroma around significant portions of the eye in this case. The uvea is visible up here. We're sort of in the area of ciliary body there, and then it just sort of blends into this pink stuff and is lost. So that starts in the front with the cornea. Eventually, it's over here. All right. So in this case, the cornea has a little bit more of a keratitis here overtly. So you do have some vascularization in the corneal stroma, and you do have some lymphocytes infiltrating the corneal stroma. So we do have a more overt keratitis. And then again, what's interesting in this eye is what's not there. So there should be a thick Bowman's layer here, and there isn't. So there's pretty extensive absence of that again. Let's see, there we go. And then we can pick it up more peripherally, but it's basically broadly absent centrally. So this case is probably also a horizontal keratopathy in a dolphin, just with a more overt keratitis, and then also some further features. So if we walk towards, here we go, the back of the cornea, let's go right here. So we have corneal stroma here. We can make it out by its lovely parallel fibers. And then we have a much more disorganized fibrovascular tissue lining the back of the cornea. And then we have this very thin basement membrane, which is all squiggly and labyrinthine. So this is a broad separation of Descemet's membrane from the corneal stroma, and we have basically a fibrous or fibrovascular reaction in between that. So this is a true in vivo Descemet's membrane separation from the back of the cornea, and in this case, it would be most likely due to ocular trauma. And then the rest of it is just confirming for you on a closer look, all that pink stuff inside the eye. It's fibrous to fibrovascular tissue. So this is thesis bulbi in a dolphin as well. And in addition to there being a globe full of fibrosis, which is basically also kind of involving the uveal tract, which is multifocally or segmentally absent, there's no lens tissue, at least anywhere in section that we've been able to pick up on. And I should point out that, be more specific on the gross, the lens was identified and retained in the left eye, but they didn't identify the lens in the right eye on their end either. So this is presumed chronic sequela of ocular trauma in a dolphin, as well as the background of the horizontal keratopathy in this eye. And the lens is presumably on the ocean floor in this case, rather than on the carpet. But most likely the lens was extruded at some point. The clinical history is rather suggestive with the sort of protruding tissue from the cornea that kind of decreased over time. Suspicious for a corneal defect at some point, and then this is kind of the chronic healing or chronic sequela after that. So first we had ocular trauma in a cat, and now in a dolphin for you. And then also the very interesting corneal conditions in this animal. Briefly, horizontal keratopathy in dolphins, I think the cause is still being investigated. Potentially implicated causes are maybe water quality, maybe UV exposure, UV radiation, and I'm not sure if it's necessarily been pinpointed yet exactly what causes it.
Is it seen in wild and captive, or only captive? Or
I think it's been seen in both, but maybe more frequently captive. Don't quote me on that though. Okay. There is a paper out there. The one that I cited is a really good paper to look into, because they looked at both some wild and captive dolphins in that paper. And yeah, corneal disease is one of the most common things that they found in their dolphins in that paper. So here's a long list of diagnoses, dolphin diagnoses. Yeah, I didn't mention that there also wasn't any retinal tissue seen in the right eye at our examined section. So at least detachment, and then unclear what else may have happened to it. All right, I'm going to move from the scope.
All right. So next up is a 4-year-old Labrador Retriever. This is the left eye. I've got a nice clinical photo of what this looked like. It's a copy of a scanned, printed out photograph, which is why there's a little bit of artifact in the picture. But this dog, the left eye was small and non-visual since puppy, and presented in mid-December last year for evaluation with a central corneal rupture, and aggressive corneal vascularization and protrusion of the central cornea. And then fast forward 3 months to the beginning of March with the findings of the eye chronically rupturing, and the owner elected enucleation. The other eye was normal in this dog. Other pertinent history is the dog is epileptic and is on chronic phenobarbital treatment, and there's some mild elevation in liver enzymes secondary to that treatment. Otherwise, dog is normal. This monstrosity here on cut section, here is the globe proper, and then we have this explosion of tissue kind of out through what's maybe left of cornea, maybe up here somewhere. Could not find a lens anywhere. There's some nice orange coloration here, so some nice chronic hemorrhage involved, and couldn't really tell what was maybe going on with the retina or the optic nerve in this case. So let's take a look. All right. Same orientation, the cornea, or where it once was, it was up here, and all of this nice red tissue, lots of hemorrhage in here. Heading back, you can see maybe a little bit of the uvea still present at the periphery with the pigmentation in there. And then, found the optic nerve here, and some like fibrous tissue in here, indicating nice chronicity here. Again, couldn't find the lens, probably extruded. Here, let's see. All right, let's find, all right. Sclera, you got uvea here, trying to head towards the front of the eye. Maybe ciliary body here, and then we just kind of lose it. And cornea was maybe somewhere along here. But it's sort of all been effaced and exploding through by this tissue. So we walk around here. And what's in this tissue is a lot of hemorrhage, and what we have are abundant macrophages that are very foamy. And then there's also these crystal material here within the macrophages. It's nice little spicules. Can you polarize on this?
Acicular.
Yeah.
Oh, the lens is down below there.
The lens should be somewhere around.
It's right on the. It's under there.
Oh my goodness. Oh, here. I'm gonna try to polarize this for you
I don't know
guys.
how it works. It's the camera.
Oh, look at that.
Perfect.
Not gonna move.
Ta-da!
Yay! It works. So birefringent acicular radiating crystals here in the macrophages that are, again, very foamy. Here we go. Here's a nice little indication, nice little like bubbliness to them. So indication of lipid phagocytosis, being phagocytosed here. There's neutrophils and a few other like lymphocytes, plasma cells sort of scattered around here. But it's a pretty repetitive finding throughout the entire vitreous here, and sort of replacing and effacing all the structures in the eye. I'm trying to head back towards the optic nerve. Here we go. Aha. So again, back in the back here, this nice dense fibrovascular membrane that's also sort of got some acicular clefts in it, so some cholesterol. There's this nice tan orange material, suggestive of or supportive of hematoidin, and some brown pigment, which is probably hemosiderin, so just chronicity to this lesion. Again, the chronically ulcerating lens for about 3 months, or cornea. And then if we look closely, rarely, in some of the blood vessels here, go.
It's beautiful.
All right. Ooh, sorry, tried to get this right in the center. So we have the lumen of the blood vessel here, and then the wall is expanded by more foamy macrophages. So this is indicative of atherosclerosis in this patient, which sort of goes along with lots of lipid and stuff from this lesion. Couldn't really find the retina either, so it's probably detached, maybe even extruded. Maybe it followed the lens out. And here's our optic nerve head, which is pretty gliotic, and it's got some hemosiderin in it as well. So these findings was a really nice example of Xanthogranulomatous endophthalmitis, so an indication of all that lipid in there. It's also known as a solid intraocular xanthogranuloma. Again, with those birefringent crystals, and then we had some atherosclerosis in a couple of the cells there. Interestingly, this condition is usually bilateral. It's overrepresented in schnauzers, which are, I guess, the poster dogs for high cholesterol. And it's also often diagnosed in diabetic patients with a hyperlipidemia or hypertriglyceridemia, which, if you remember, the signalement of this patient was basically none of these things. So it was a unilateral Labrador retriever, so not a schnauzer, and no indications from the blood work. They only mentioned the mild elevation in liver enzymes from the chronic phenobarbital. But I did find that chronic phenobarbital use can cause hypertriglycerides. So we asked and haven't received a response if maybe the triglycerides were elevated in this patient, given what we were finding. But the atherosclerosis kind of supports a hyperlipidemic state in this patient. It was just kind of interesting. Oh my goodness, I forgot one of the more fun things. Let me go back to the histo. The crystals are also alcium blue positive. So this is an alcium blue PAS stain. And the crystals are nice, bright.
Ooh.
Yeah, everybody, woo, ah.
Chromotherapy moment of the day.
So, sorry, I did the stain specifically for rounds, so it wasn't on my radar from the case. But there you go. So a nice little fun fact for these crystals.
You don't have the back of the eye there.
I don't think so. I think I took it from a side section, just because I wasn't sure how well fixed that large mass of tissue was in the globe, and was trying to just get a smaller piece for histo to handle, sort of thing. So a nice example of Xanthogranulomatous endophthalmitis.
And a weird dog.
Dog.
Atypical.
Not a schnauzer.
And young.
Not bilateral. So all that stuff. Okay. Looks like we are over time a little bit. But lots of cool cases today. And thanks for joining us, and we'll see you guys in 2 weeks.